giving up on, they get to the point like he's up giving up on.
Want me to see it?
You can put it up on the counter, kind of pointing down.
All right.
That-
Do I have a patient?
Patient,
Step right up.
what am I doing?
Well, first, I'm going to demonstrate the finger. I'm going to have you sit on this stool, sir. So you're seated sideways to the table. Now then, I'm going to raise.
My wallet.
Go ahead and scoot forward just a little bit. So this is the finger exam. I want you to place your left hand right on this plate for me. One thing you notice, you see how his forearm, his forearm isn't straight, isn't in alignment with his hand. I'm just going to move the IR so that we have the long axis of his hand in line with the long axis of the forearm. I'm placing his hand so that the area of interest is centered to the IR. His fingers are spread apart slightly, but I'm going to tuck that thumb in a little bit. So, which digit is the affected digit? So I have lead markers here, 2 through 5. And when you simulate this finger, I'm just going to shake them up and draw a finger. And that's the finger that you'll simulate. So I'm going to put this 3 right at the end of the third digit. I'm going to use my left marker because this is his left hand. Bring my tube over. My SID is 40. Your SID is 40 on all of these upper extremity projections. And you have to manually measure. 40. So I'm going to center to the third MCP joint, the third metacarpophalangeal joint. A couple ways you could do that. I can move my tube to do that, or I can just move the IR.
So will you take off if we move the IR?
No, to me, I mean, in this instance, it's the smart thing to do because you're not straining with the tube. And, you know, it's not an exam where if I move the IR, you know, he's not in an uncomfortable position. I can move it easily. So I have my SID set at 40. I'm centered at the third MCP. What you want to make sure that you do, and we haven't done this before, so that your collimation borders are parallel to your IR, you move your collimator box. You see the difference?
Do you have to push a button to move it?
No, it just moves freely. You can move it like this, or you can move it the other way. But you can see how it makes sense to move it toward you so that when you collimate, the controls are right here. So I'm going to collimate down so that I have 4-sided collimation. I'm including the distal 1 inch of the forearm. I have my 3-digit included. I can collimate a little bit more side to side. Somebody want to turn down the lights? You can see that collimation light better. Oh, it's the one on this wall.
Oh.
There you go. So I have my thumb included here. My marker, my digit marker's not too close to the finger. I have my side marker here. Shield my patient. Notice how he's sitting sideways to the table. What do you suppose my breathing instructions are?
Take a deep breath in and hold it.
Stand still, sit still.
Hold still. Yeah. On the extremities, at least the extremities that I'm demonstrating, breathing doesn't affect anything, so you just ask him to hold still. Exposure. So that's the PA finger. Oh boy, next is tricky. The oblique.
He figured out how to use it since he was being patient. Just keep it in work.
Thank you. Yeah, I just wanted
You have
to-
smaller fingers.
I just wanted to make sure.
I believe so.
Oh.
It looks like it is. Yeah, and then that would be something.
What is this for?
Whoops.
WWT? Maybe it's somebody's initials, possibly. I don't know. I don't know why the C has a. I don't know. I guess to make sure you know.
Overline,
It's an overline.
Colonel Whitford,
Okay,
wait,
whatever.
no, wait, what is it? Colonel Whitford
Thompson?
Taunton. I don't know. Colonel Whitford.
Oh, she's back again.
Oh,
I'm
okay.
not done with you.
I thought it was done.
So I have a question, when you raise the table, so will it be to a certain level that you have to have it? Or is it the same level as we had to raise the table for the KUB?
No, this isn't about raising the table for the extremities. Isn't about what you're comfortable with, it's about having the part
Level.
level parallel. Because you wouldn't want to perform the hand with the wrist raised off of the IR. You would want the wrist and forearm at the same plane as the hand, so that's why the table's raised. I think you can see.
If you
Let's
go
try
higher,
your right
if you needed
hand.
to go higher, you would just lower the chair.
There, and I'll show you when we get to other exams that it really matters.
He turned around.
I don't know if that will capture it. So for the oblique hand, or I'm sorry, the oblique finger, your hand is positioned at a 45-degree angle. And you can use this 45-degree sponge. I have a smaller one, but I don't know where it is. I'll have to find it.
Is that it, right?
That's a big one.
It's a small gray one on the side of it.
sorry.
Yeah, I don't know if that's. Yeah, I could, that's 45, you just have to make sure it's 45. Some of them, like that other blue one over there is not 45.
Okay.
That's a smaller angle. So for the third, fourth, and fifth digit, you can use the positioning sponge. You don't have to. So for the fifth digit, just place your hand on that sponge. Make sure your hand's positioned so the part of interest is centered to your IR. So you may not be able to see this. Thanks. So we've got the fifth digit resting on the IR. We have the other digits, the unaffected digits, separated from the digit of interest so that they're not superimposed. We're going to center to the proximal interphalangeal joint. Again, making sure that our collimation field, the borders of our collimation field are parallel to our IR. We're going to collimate to the finger of interest. There we go, right on there. We want to include the distal metacarpal, of course the entire digit. And that's our fifth digit. So I put my little 5 here at the end of the digit. I've got my left marker included, but just to make sure, I'm just going to open that up a little bit, that collimation. There we go. So the hand's positioned at a 45 oblique. And then my instructions would be,
Hold still.
what's that? Yeah, this is the proximal interphalangeal joint, the PIP. Yeah. And my instructions to my patient,
Hold still.
hold still, exposure. Oh man, I failed my simulation.
Hey, at least we got it on video.
There, now I've got shielding. And again, my patient is seated sideways to the table.
And you always center your CR to,
Yeah, there again,
no.
if you move your hand, Drew, my central ray is centered to my IR. Now that's for this fifth digit. The third, the fourth would be pretty much the same. Center to the proximal interphalangeal joint. Now here's where, remember I told you that the finger, the part of interest, has to be parallel to the IR? See how I have his distal fingertip resting on the IR? That would close off joint spaces. So I need to make sure I have that lifted so that it's parallel to the IR in the same plane. Still oblique 45 degrees.
4.
Now I'm going to put my little 4 here at the end. Still going to use my left marker. I'm going to open up that collimation just a smidge, make sure my 4 is included. And you see the shadow of his distal finger on the IR? You never want a marker within that shadow. Always bring it out so that there's no possibility that you superimpose anatomy with your marker. So I have a shielding. I'm including the distal metacarpal centered at the proximal interphalangeal joint. I've collimated essentially to the area of interest. I remembered his shielding this time. And he's sideways to the table. Yeah. Hold still. Exposure. Now it would be the same for the third digit too. Same. Move your hand back a little bit. Still centering to the proximal interphalangeal joint. I'm separating these fingers. I've got to make sure that this finger is not resting on the IR, but that it's parallel.
If the finger is broken, I don't know, and the patient cannot hold it.
Yeah, it's a good thing we have that
Tape.
sponge.
Oh.
So now I put my number 3 marker on, I got my left marker on,
So you're gonna open it up more.
and my teacher Antoinette tells me I should open it up more, so that's what I'm gonna do. And she is absolutely correct. Collimate and just a smidge Joni. There we go. Right to that interphalangeal joint. He still has his shielding on. He's sideways to the table. Tell him to hold still. Exposure. And again, the point where I'm centering is at the center of my IR.
Okay.
The second digit is when everything changes. So this has always been the, we're doing the lateral oblique. If we did the same for the second digit, we'd have a lot of OID. A lot of space between the second digit and the IR. So we do a medial rotation for the second digit. Now I want you to flex your fingers under your hand. And this is a little tricky. I want you to get your finger as close to that image receptor as possible.
Make it go with you.
But it's an oblique. So you have to oblique your finger. Is that easier for you?
Yes.
Let's see. I'm gonna raise your table, sorry.
Good.
What you looking for?
Tell me what I'm gonna do. Sir, is this chair lower? Is this seat lower than that? Yeah, okay, go ahead and stand up. No, I don't even, but you can move your finger. Sit there. Here's your shield back, apron. Okay. And just extend your arm. Is that any easier? Try and lower your arm. There we go. Does it hurt?
A little bit.
Uncomfortable?
A little bit.
Right here. Now again, see I don't hesitate to move the IR around and try to make it more comfortable for him. I have my second digit here, my left marker. Still have the distal metacarpal included. You want that finger rotated at 45 degrees. You have the unaffected fingers flexed under that finger, centered at the proximal interphalangeal joint. Sideways to the table. My SID is still at 40 inches. Well, I moved my tube, so that changed a little bit. Good thing I checked it. Okay, sir, hold still. Exposure. That's the oblique. Now for the lateral. I don't know where all the sponges have gone to.
No.
Probably try and put the tripod down, so it's the whole.
It's because my arm was like bent in.
Was it intro? Here, let me move the wheelchair.
I think it's fine, just like, right here.
There, there.
You put those and put that.
Here's at the bottom.
I don't think it's that.
Level, I mean, it doesn't have to be exactly level, but you could probably just leave it there and be planning on all of.
Make sure they're out.
Oh, all the way.
Yeah.
Okay, this one is.
I'm not a cameraman.
Good job, cameraman.
There you go.
Why does it think it says January 1st, 2008 on it?
You're fine, the center. Yeah, I don't know, it's good.
Are we good?
Yeah, just did a little.
That looks like it's right on me though.
It's not.
That's right on the table.
Oh, okay. So now for the lateral finger.
I made sure not to get your face. I didn't think you wanted your face in there.
What are you saying, Steffi?
No, I just didn't think you want it.
Scoot up just a
You have a
little
great
bit.
face.
Forward. So, the fifth digit. So, to help you keep the unaffected fingers unsuperimposed from the area of interest, you put that block sponge next to the fingers. I'm centering at the proximal interphalangeal joint. And make sure I turn my collimator box so that the borders of my collimation field are parallel to the IR. Centering to the finger of interest. That's my fifth digit. So I include a 5. I place my left marker on. And again, the center of my central ray is centered to the IR. My patient is sitting sideways to the table. I want to check to make sure his finger is lateral and not rotated. My SID is 40 inches. Just tell my patient, hold still. Exposure, and he does have shielding on. Awesome. Now, for the third and fourth, it's pretty much the same. Now, you have to use something to block those other fingers. Try and do that. You can't do it. It's impossible. What?
These two are attached together
You
with a
can't do it.
tendon.
With your ring finger, your fourth digit?
Oh, I guess I
To be pulled.
No one can.
No one can. These two fingers are
What?
attached to each other.
No?
I did a little bit of smooth straight.
So again, for the obliques, you don't have to use a sponge for your simulation, but you do for your laterals, your fifth through third digit. Let's open up that collimation a little bit. Make sure that our markers aren't in anatomy. Centered to the proximal interphalangeal joint. This finger is parallel to the IR. If the distal finger were touching the IR, that wouldn't be acceptable. It has to be parallel to the IR. Patient has shielding. We're at a 40-inch SID. Sideways to the table. Hold still. Exposure. Oh, I had my fifth marker on there. That should have been a 4. Ooh. Some editing. The third digit, just the same. Making sure that the unaffected fingers are blocked out of the way. What's so funny?
He's flipping us off.
He's being very mature.
We are professionals here. The
We're all
fingers
children.
parallel to the IR. You scoot your hand back a little bit as we're centering to the proximal interphalangeal joint and also centered to our IR. The fingers extended parallel to the IR. We have our left marker, our number 3 to mark that that's the 3rd digit. He's shielded.
Do we have to center this one? I'm just asking, so do we need it?
No, you're right, that's proper. And that actually is, here we go, that's centered. If you would move your hand back a little bit, please. There. Bring that forward just a smidge. Now then. We're centered to the proximal interphalangeal joint and we're centered almost to our IR. There we go. Including the distal metacarpal. Hold still. Exposure. Now the second is different.
Can we-
Naturally.
Can we say pip joint in simulations, or do we have to say proximal?
You could say PIP, but you have to know what it is.
Yep. Okay. Just didn't know if it was something that would like fail me if I.
No.
Even if you don't pronounce it right.
So when we're doing this, it's kind of hard to do it because the sponge shifts because it's very light. So when we have our finger out here, but I'm trying to keep it still.
Mm-hmm.
But sometimes, like, because of where my fingers are positioned, it can move a little bit.
It can, but this sponge is actually better than the others. If I could find them, I'd show you. But there is a different sponge too that I'll try to find. It's a square. But if it moves, if it moves slightly and you're still centered, you're okay. But if the hand moves and you're no longer centered, then you have to correct it. Now the second. So this would be, if you're talking about anatomic position, for the second digit, a mediolateral, lateral. Again, you have the long axis of the finger parallel to the long axis of the IR. The proximal interphalangeal joint is centered to the IR.
The tip of the finger is not powerful.
Okay, I'm sorry.
What?
It's not right.
Is he
Fingers
not
bent.
behaving?
His finger's not straight.
Yeah, he's bending his finger.
But that's a good point. You've got to make sure that when you're doing the lateral for the fingers, you've got to make sure that the finger is lateral. And you can do that pretty much by looking at the fingernail. You can tell if the finger's rotated. And we're going to use our second digit marker with our left marker.
Do you not want the left mark on the other side? I'm just asking.
Yeah. You guys are precise. I love it.
It's because of the camera.
Okay. Still at 40-inch SID. Fingers lateral. Touching the IR. Hold still. Exposure. What?
No, I was asking, like, can we reduce it to here because while we're doing the second one, we're doing like up to here.
Well, you're including the distal metacarpals?
Ah, that's, okay.
Mm-hmm. But, I mean, and if you collimate it more,
Is the
you
cushion in
could
there?
collimate a little more,
No.
but there again, if you collimate too much, you're gonna cut off the digit marker. And that's what a lot of people do. They'll wanna collimate so much and then they'll get this marker right in here next to the soft shadow of the soft tissue. And you don't wanna do that. You don't wanna risk having that marker superimpose the soft tissue on your finger. Okay. Thank you, sir. Shall we have someone else be the
Sure.
patient for the thumb?
Oblique,
I'll
and
do
last
it.
one, we just
Thanks, Anthony.
with motion. Like for oblique, can we use to
Mhm.
the sponge, but use the other side of the sponge to do oblique?
Mhm.
On the second digit,
When you say other side,
like we did like this, all obliques, yeah?
right,
Can we do like? so-
you can.
So it
You can
really
stay
doesn't matter what side of your hand
close
is on
to
the
IR.
sponge?
Well, that's, I had demonstrated it like that,
Uh-huh,
but if you're using the sponge,
I assume yes.
be on the other side.
yeah,
Oh,
you
okay.
can do that,
Mhm.
WTF.
yeah,
I know
you
it's
can
a
use the
volume,
sponge.
but
Okay, for the thumb.
well, that's why we're talking about it.
This is the trickiest position out of any of the upper limb that you're going to do. You know how I told you that for the finger, thumb, hand, wrist, you do a PA, 45-degree oblique, and lateral? I lied. For the thumb, it's an AP thumb, not a PA. So, yeah, nope. You start this way. So you're actually pronating. There you go. Yeah.
It's like weird watching.
Aren't you
Now-
glad you picked this one?
You see when he's done this, that leaves the thumb rotated? Sure.
Sorry.
So rotate that hand until you've got that thumb
Parallel.
so that you have it truly AP. It's not rotated. You're centering at the first. When I say first, I'm referring to the thumb as being the first digit. The first MCP joint, metacarpal phalangeal joint. Let's make sure then that that centering point is in the center of our IR. Let's see. Bring this up. There we go. I'm going to move your arm. You see again how his hand isn't aligned with the long axis of the forearm? See how I did that?
That's a little more comfortable.
What?
So that's a little more comfortable.
Oh, good.
Patient's comfort is the main concern here.
Not really.
Oh, dang.
Strike that from the record.
They're already uncomfortable.
Right.
Now, when you collimate for the thumb and when you center, remember for the finger, I said you include the distal metacarpals? Well, for the thumb, you include all the way down to include the trapezium. So you've got the entire metacarpal, first metacarpal, and the trapezium. Make sure that there's no rotation on the thumb. We've got our left marker. For the thumb, a digit marker is not needed. If the radiologist doesn't know that's a thumb, just saying. We're gonna give our patient shielding. Let's make sure that we have a 40-inch SID, which we do. Centered at the first MCP, we have our left marker. Just rotating that a little bit more so that the thumb isn't rotated. I'm gonna tell you to hold still, exposure. You have to be really careful that these other fingers
Not like.
don't get in the way of the thumb. Okay, so that's the AP. Now for my next trick, place your hand flat on the IR. And look at this, folks. Your thumb, naturally, when you place your palm on the image receptor, is at a 45 oblique. But you've got to make sure to align the long axis of the thumb to the long axis of the image receptor. We're still centering at the first MCP joint, metacarpophalangeal. We're opening up that collimation to include the trapezium. I mean, the thumb is really easy. Technically, the oblique and the lateral thumb are just, it just doesn't get any easier. What you need to practice is the AP thumb. Yeah. And make sure that when you have the arm position for the AP thumb, that you've got the long axis of the thumb in line with the long axis of the forearm and I don't know, not this crazy business. All right. There we go. All right. Centered at the first metacarpophalangeal joint, MCP. Thumb's position at a 45-degree oblique. You say oblique, I say oblique. You see how I had position? I'm just going to straighten that out so that the thumb and the forearm really are in alignment.
So I see you keep moving the marker, so does it matter which side we put it on?
Well, I was trying to be technically
Makes more
correct
sense
as
on this side.
as
This
I.
one, I feel like.
You weren't at the most lateral.
Yeah. Honestly, it doesn't matter to me if you put it here or here. I was just trying to stay consistent with what I had said in class, like
Okay,
meeting lateral side, meaning away from the midline.
okay.
Yeah. Okay, hold still, exposure. Okay, this is where it really gets tough. Watch this. Oh, yeah. This is what I want you to do.
And we don't need to use a sponge on this.
Nope.
So,
Nope.
yeah.
Sir, wait for my instructions, please. I want you to arch your fingers. Not too much. Why is that funny? Why is that funny? I'm guessing. What?
You did it.
Makes me feel self-conscious.
What?
Nothing.
It's only on camera.
Well, you arch the fingers. You see what that does? That when you arch the fingers, that naturally rotates your thumb into the lateral position. Did you get that, Drew?
Yes,
Can you see his thumb?
a little bit.
So put your hand flat again.
Yeah.
That's how it was for the oblique. Now I just want you to arch your fingers. Okay, good. So you want to be careful that your patient doesn't arch the fingers too much and over-rotate the thumb. Bring your fingers down just a little bit. There we go. Still centered at the first metacarpophalangeal joint. Center to the IR. I'm including the trapezium. My finger is lateral, or thumb is lateral. Patient seated sideways to the table. That's shielding. Hold still. Of course, for your simulation, you're gonna run back here. Hold still, exposure. Okay, that's the thumb.
Just want to make sure I got it all.
Thank you, sir. You wanna stay for the hand or you want something
Sure, I'll
else?
stay.
Oh, yeah, that's.
I like
great.
sitting, so.
You're a good sport.
So this is the hand, just put your hand flat on this cassette. Again, I've got the long axis of the hand positioned in line with the long axis of the forearm. And just separate those fingers a little bit, and remember. What?
No, she's tired, it's like staying, it's like, go sit. Be patient.
Sit. Yeah. Tuck this thumb in, you don't want this thumb positioned way out here to the side. So you want it slightly separated. We're gonna center, just like we did for the PA finger, at the third metacarpal phalangeal joint. We have the borders of our collimation field parallel to the outer edges of the IR. We're including about a distal, or an inch of the distal forearm. Hands flat on the IR. Include our left marker. Our patient sitting sideways to the table. 40-inch SID. Patient shielded.
Hold still.
Say it, Internet.
Hold still. Exposure.
Awesome. Yeah. Here's where it gets tricky too. The oblique. Okay. All right. I don't like the sponge at all. Use this. You can use this 45-degree angle sponge. This is the oblique hand. You want to make sure that you have the fingers separated. Rest that hand, okay. I have his metacarpals and his finger, his fifth digit, resting on the IR. Before I reposition him, his metacarpals were not on the IR. But we want everything in the same plane, the metacarpals and the phalanges. Separate those fingers a little bit. And you're centered to the second MCP, metacarpal phalangeal joint, for the oblique hand. Make sure that that thumb is in the collimation field. We have the left marker on. Our fingers are parallel to the IR. Our central ray is centered to our IR. We have our left marker. Hold still. Exposure. Wait, that's not right. Where does it say to center for the oblique hand?
Keep fingers separated from the eye here, and it's aligned with the long axis. Outward, directed to third.
Third. That's what I thought. Scratch that. Third. So for the oblique and the PA, your centering is at the third MCP joint, not the second, the third. Right there. Now hold still, exposure.
Changing IR.
Yeah, I'm doing that. Now then, you could use this sponge. I don't like it. I think it has a tendency to mess students up even more, especially if you have somebody with a really large hand whose fingers don't rest on this sponge in a way that keeps the fingers parallel to the IR. Sorry about that. But you may use it. I want you to come around here and notice that Anthony's hand is rotated. And this is what I mean. Can you
This is
tell his
not
hand is
touching.
rotated?
Yeah, it's not touching, you still got space between there. You have
But then
any
my
space.
fingers don't line up.
You have to be careful for that. That's why
You need
I'm
a
not a
taller
fan of the
sponge.
sponge. So, I'm gonna position his hand laterally. You wanna separate the fingers. Each finger has to be fully extended. If the finger is flexed, that will result in closed joint spaces. So this takes some careful positioning. Fingers are separated, fingers are extended, and they're all parallel to the IR. This is not acceptable. You've got to get that hand parallel because when you have the fingers separated, and you want this, you're not hitchhiking. Yeah, you don't want the thumb up. The tendency is when you start to separate and position the fingers, the tendency is for the hand to rotate medially. So you want to be sure after all is said and done that that hand is kept lateral. Now for the lateral hand, you center at the second MCP joint. Still shielded, still at 40 inches. Hold still, exposure. You can
You really have
relax.
to do that one fast if you don't have any, like a sponge or anything to keep that hand in the position that it's in.
You see for me, what?
Oh,
Talk to
okay,
me.
yeah.
No, nothing.
No, come on, what's up?
No, nothing.
Why don't you sit down?
No, I'm fine.
You see, mine hand, I can keep it lateral and use the sponge, but I think,
It's a taller hand or wider hand. It's
right, wider hands, when you get those fingers resting on the sponge, your hand rotates. So be careful of that. All right. How about the wrist?
Sure. Keep going.
All right. What you need?
What do you call what you just did, the position?
Lateral
She's
hand.
And that's
PA.
the same as the one that you did on the other sponge.
No, that was the oblique.
Oh, okay, okay.
Yeah. That's the oblique at a 45-degree
That's
angle.
lateral.
And then the lateral is
Okay.
No, that's
when the
what she
hand
was
is
asking.
completely lateral, yeah. All right, here we go, this is fun.
Sorry, I just not something caught on my finger.
Put the palm down, okay. Now see, I can move the IR. Don't necessarily have to move him. Starting at the wrist. For the wrist, the forearm, and the elbow. The shoulder has to be in the same plane as the rest of the upper limb, meaning at the same level, like this. There are two ways you can accomplish that. You can have your patient scoot forward in their chair. So scooch, just don't scoot the chair, but you scoot forward in your chair and lean back. All the way back. Do you see now how his shoulder is at the same level as the rest of his upper limb?
Oh, question. The last, projection and position that you had, I thought you said that was the PA oblique hand.
It is. Not the last projection was the lateral, but when I demonstrated the oblique, it technically is PA oblique.
Okay, because the central rate, that one was 2 at the second digit.
For which one?
the MCP, the lateral hand.
Right.
So it was the second one, but I thought, cause you had just got done doing the PA, and then I was looking at, the PA hand, then PA oblique, that's the one I thought you were doing, so I put that, that's what I gave the information for.
So the PA oblique, the centering is at the third
Yes.
MCP,
Uh-huh,
and then for the lateral, the centering is at the second MCP.
okay. Okay, I just need to, I just look at the video.
Okay. Yeah. So you can have your patient scoot forward
Slouch.
and slouch back to get that shoulder at the same level as the rest of the upper limb. Or you can MacGyver it and find Kleenex boxes and whatever,
Foam pad.
boxes, gloves to build up your IR. So you could set up. You could do that too. But then make absolutely sure if you do that, that you, uh-oh, now look what's happened.
Lower the table.
I can't get,
40 inches.
yeah, but if I lower the table, yeah, I can lower the table.
Then the shoulder's not level. Now you need to slouch and use the box.
Oh, it's because the chair's
Oh my.
underneath and it's bending the chair. I was like, something felt weird. I was like, what the? Like that.
The oxygen too.
The chair's wedged under now.
No, you.
Are you okay now?
Oh, I'm
need to hit
fine.
the up one, up.
It's crushing.
It's
Because
crushing the
it's
chair.
crushing
The
the chair.
chair is stuck under the table.
Does anybody know how to edit video?
I think it'll be funny with bloopers.
Funny for
Like
who?
I said, blooper reel. We gotta have it.
I'm not, no. So, you see what I'm, yeah, now you have to slouch a little bit. There you go. Okay. You crazy kids. Making fun of the old lady, that's not nice. Okay, so we're centering to the wrist. Mid-carpals. If you look under here, look under there. Do you see a little gap between the wrist and the IR?
Mm-hmm.
Well, to take that out, we're going to have our patient arch his fingers a little bit. So that reduces the OID. Yep. Yeah?
It,
No?
it did now, yeah, it didn't at first.
Okay. Now arch the fingers, there you go. And that's what you do to reduce the OID. You get the wrist now in contact with your IR. You're going to include the distal forearm and the proximal metacarpals. We'll put our left marker on here. Our central ray centered to the mid-carpal area and the center of the IR. His shoulder is in the same plane, at the same level as the rest of his upper limb. He's seated sideways through the table. He has a shielding. I have a 40-inch SID. I have my left marker. Hold still. Exposure. That's your PA wrist.
Okay.
Now, for your 45-degree PA oblique wrist, you rotate the hand and wrist 45 degrees. And this is what you have to eyeball and get used to, what's 45. Because when you position for the PA oblique wrist, you are not going to use a sponge. So you have to know what 45 degrees is. I have something that measures that, but I don't know where it is.
So this is the only one we can't use the sponge with, or we can use the sponge with the others? Cause I think I put sponge.
For the oblique hand and fingers, you can use the sponge. Excuse me. So we have our hand and wrist oblique at 45 degrees. We're centering mid-carpals. Now here's what I want you to notice. When I rotated the hand so that he's at a 45-degree oblique, I didn't change my centering, but you'll notice there's less light on this side than there is on the other. I want to center so that the amount of light on either side of his wrist is equal size. So I just center over just a little bit. Again, make sure I got my left marker in the collimation field, center mid-carpals, including the distal forearm and proximal metacarpals. Yes.
Space there is it okay?
What's that?
The cup.
There's a space between his.
It has to be, because it's an oblique. Yeah. So his wrist is positioned at a 45-degree angle. Hold still, exposure. Turn your hand, wrist laterally. Just lean forward a little bit.
So on the last one, on the PA oblique.
That was the last one that I did.
You stated that, the distal forearm and the proximal metacarpals are going to be included in
Yep.
anatomy, okay,
And that's for every projection of the wrist.
okay.
Yeah. So now I want to make sure that the hand and forearm are lateral, centered mid-carpals. Have my left marker. I'm still centered to the IR. My central ray centered to the IR. His shoulder is still on the same plane. Actually, to me it looks like his shoulder is a little lower than the rest of his upper limb. So I'm gonna lower this just a smidge. I have to check my SID again, make sure it's 40. Okay. Still has his shielding. Hold still, exposure. Thank you. Still wanna go? Someone else? Okay.
Someone else. Kind of